Welcome to the Non-Obvious Beyond Diversity Summit. I'm your host, Laura Evans. I'm president and founder of Laura Evans Media, and I'm a former anchor and reporter here in Washington, D.C. It's such a pleasure to be with you all today and speaking at this summit and speaking with an incredible lineup of speakers and panelists. I want to introduce them very quickly here. Dorcas Lynn, she is president and founder of Diversity Health Communications. Elisa Gus is CEO and co-founder of Wishnich, and Allison Kalu is patient recruitment and diversity consultant and founder and CEO of Clinical Ambassador Incorporated. Such a pleasure to speak with you all. It's a great lineup, and I know you have so much to bring to this incredible conversation. And so I'm looking forward to speaking with you all. And we hopefully will have one more panelist joining us as we go along within the conversation. So this is an eye-opening panel, a discussion that we really need to have called Health Equity, Why Diversity Matters in Public Health. It's a critical conversation that is so front and center in our public conversation in our country right now. And thanks to our organizers, the team at Non-Obvious Company, for inviting all of us to be part of this very special and important event. It's a critical conversation, as I mentioned, and we all appreciate the opportunity to disseminate this information and hopefully to spark new conversations. Before we begin today, the organizers have suggested a really beautiful and uniform way for all of us to begin our sessions. And I would like to participate in that by taking a moment to reflect upon the history of the indigenous lands that we call home. While we are meeting today on a virtual platform, all of us occupy spaces that carry the powerful legacy of these diverse peoples and their unique local cultures. Through this acknowledgement, we reaffirm a deep commitment to improving our understanding of America's shared heritage and recognize our collective responsibility to improve the bonds between all nations. We are grateful for the opportunity to meet you wherever you may be on your journey toward a more diverse and inclusive society so that we can do the work together. So with that, I want to say that we have all lived through a year where public health has taken a central role in our lives and our livelihood. We can all say that for sure. And today we are talking about how diversity and inclusion play a role in how public health initiatives take shape. So we turn now to our panel of public health leaders for some thoughts and some answers in a truly pivotal moment. Ladies, thank you so much again for joining us. And Dorcas, let me start with you. Can you lay out simply what the problem is that we're facing right now and talk about the imbalance that we are seeing currently in diversity, the lack of inclusion, and what this means for healthcare at this moment?
I think we can begin to address that question with one simple word, and that is trust. And what we're seeing is this incredible divide in terms of a catastrophic crisis that we now have been living through, soon to be almost 12 months, 1 year of chaos in terms of leadership in being able to manage, contain, and engage trust with the people within our nation, within our states, and within our communities. I always think about the notion of the privilege of participation, and particularly as we look at what we're facing today, which is the opportunity for a public trust in a solution to the pandemic crisis through vaccines. We are finding that those communities that are in most dire need of access to vaccines are the ones who are being the least afforded the opportunity and access. I always think about how we usually talk about the issue of trust in clinical trials in particular and public health campaigns in particular, because we know that even if we get access and availability to those populations, we often find that those communities who have been most mistreated and abused by the system are the ones who are hesitant to participate in them. My grandmother was part of the original US public health trials, and in 1946, she woke up after giving birth to my mother to learn that she had been sterilized without her consent. And so to be able to convince one generation, two generations away today, that there is privilege in participation in public health trials, it's a huge leap, and we have a lot of work to do in establishing trust so that there is equity and access.
Well, let me talk about that then with Allison, going on the trust angle here. And thank you for that, Dorcas. And that's such an important point that you bring up. Allison, I know as a patient recruitment and diversity consultant, you probably see that a lot with the lack of access every day, the barriers to care, the problems with simple language, and the trust that evolves out of that. What is it that is going on? What is the problem? Is it just language? Is it meeting patients where they are? Is it the lack of communication? What do you see as kind of maybe the top three or the main issue that is creating a problem with diversity, access, and lack of inclusion?
Thank you for the question. The answer is yes.
All three and more.
Yeah. I like to say that we hold these truths to be self-evident, that Black and Brown people across the country have reason to distrust a system that has routinely failed us in all the ways that matter, not the least of which included using our bodies, as Dorcas alluded to, for experimentation without concern, without consent. Despite these egregious slights and our justifiable outrage, we would still do ourselves a disservice to ignore the sacrifices, the progress, and the evidence that does exist of a shift, of a deeper commitment to the evolution of this democracy. Given the coronavirus's impact on Black and Brown communities, our informed participation in clinical trials is absolutely essential to ensure the vaccine works, regardless of age, gender, and ethnic background. But since Congress passed the National Institutes of Health, the Revitalization Act in 1993, requiring federally funded research projects to include women and minorities in their trials, not much has changed in terms of disparities in health or in the breakdown of who study participants are. And COVID just happens to be a handy example. It's also the most urgent. Mm-hmm. We just inaugurated the first Black and Brown woman to the vice presidency of the United States. Don't think that things can't change. Mm-hmm. But what I would say to people is that we are all an intrinsic part of that change. The system, healthcare and research and drug development as a whole must embrace its own change and move with all due haste toward a deliberate departure from the status quo.
Thank you. And Elisa, let me get your take on this, because you handle the data piece of this. Where do you come in, and how are you finding the data is playing into this, and what are you seeing in your space?
That's a great question. And the reason we created Wishnish is because we are seeing how the lack of access to data was affecting the trust of just about any sphere of our lives, from healthcare to commerce to education. How are you supposed to really get firm view of what's going on in your country or even in your neighborhood if you're not getting access to the kind of data that you're unable to change and that you can trust, when you're formulating your policies or when you're making a decision whether you can go and trial out the vaccine? And that's where we feel that we need to create a standard of care in that sense, a standard of trustworthy data that's immutable, that cannot be changed, and that we know reflects the reality around you. How can I ask my mother to participate in a trial when I'm not sure that, the information about how safe it is not being changed and applied? And how can I ask anyone else to change the policies if, again, there might be so many groups out there right now who are not happy with the status quo, or actually happy with it too much, not to want to change the existing data. And that's where we come in, allowing those diverse data silos to become a single data lake where everyone can draw from and can believe in. And the fact is, it doesn't have to be us. It really just needs to be groups, watchdogs, that are able to verify it, that are able to host it, and that can serve as a support system for both private citizens and the government in that search for the truth in reporting.
And you deal with blockchain. Do you see a shift with companies, with healthcare organizations, with insurance companies starting to move toward the use of blockchain to protect and build trust and help consumers understand that there is an opportunity here and an opportunity to trust?
Actually, yes. Interestingly enough, previously our customers, and in fact our base, has been outside of the US, because the reason the legacy systems are called legacies, that they work, and that's what made us, first world countries. So right now, that's shifting. People are seeing the profound need for change, and so suddenly the stakeholders are waking up to the fact that this profound change needs to happen, and so they're now open to having conversations, to beginning the installation of the technologies that are providing this change, potentially to immediate detriment of their bottom line. But eventually, they're seeing that there is going to be an improvement to that same bottom line, because it breeds trust and it breeds, I guess, customer loyalty and government loyalty to the system. Mm-hmm. So there is a trade-off, but there is definitely a lot of openness to this now.
Allison, what are your thoughts about that, and where technology plays into this, and how technology can help build trust? Are you cynical about that, or do you feel like there is an opportunity and that shift can make a difference?
Technology is a key driver. It has to be employed. I mean, there had been hesitancy to include minorities in clinical trials previously, under the impression that we did not have access to the technology, to smartphones and to the internet and so forth, when it has been disproven. And it's quite obvious, based on the social media presence, that if we employ that properly, that we can make a difference in the messaging and in the platforms that are used and in the conversations that we engage in. Mm-hmm. Just the awareness piece and driving the normality, if you will, of the concept of participating in clinical trials. Mm-hmm. And I think that technology definitely has a role to play in that. Mm-hmm. And embracing the inclusivity of people's access to technology is part of that piece as well.
Mm-hmm. And what about, and Dorcas, I want to ask you about this as well, but what about doctors and going to, and I want to talk also more about the clinical trial piece, but getting the medical community to represent the patients it serves, and going back toward where, getting more doctors who look like the patients who are going to see them. We have a situation where doctors are underrepresented in the Black and Brown community, and it's becoming a bigger and bigger issue as the years go on. How do we change that, and what can we do right now? Allison or Dorcas, either one of you can take that.
Sure, I'll start. I think a huge part of it is, especially when we look at the public health piece of it, right? The public health piece is, what do we need to look at from a social determinant perspective, a population health perspective, so that we do the most in society that addresses education and economics and safe housing, all of the things that actually help prevent our populations from needing to use the medical system. And so when there's a breakdown in that population health and social determinants of health, that's when we see so much excessive use of our medical system for illnesses and conditions that are very much approachable and solvable from a public health perspective.
Mm-hmm.
I spend a lot of my time working on programs and campaigns to really start looking at the development of talent for the medical and public health communities earlier in the pipeline, so that we're not wondering when we look at, first year medical school enrollment, why is there such a lack of diversity? We want to look lower down into the educational process to figure out how do we encourage individuals to actually see public health and medicine as opportunities for a robust and rich career that they can actually pursue and see for themselves as a reality, even if they don't have those role models in their direct life or in their community.
Yeah, the American Association of Medical Colleges says about 2.6% of the nation's doctors in 2019 and 7.3% of students enrolled in medical school in 2020 identified as Black or African American. And studies show that patients who trust their doctors are more likely to follow up and follow instructions and keep following up on those appointments. So it's a critical piece. Allison, I want to get back to what you were talking about regarding clinical trials, and there has been a history of issues with low participation, low minority participation, and barriers, financial barriers, and low overall participation. But I want to address the reimbursement piece, because I work with an organization called Lazarex Cancer Foundation. They're the only organization that reimburses patients for out-of-pocket travel costs. And I would love to hear your take on whether that reimbursement, do you believe, could be a real shot in the arm for patients to break those barriers and to make a difference for patients who need to get to clinical trials, because that breaking those barriers is so important. And are there any other ways in that you've come across that can help break barriers to get to clinical trials?
Absolutely, reimbursement and remuneration is essential, but it's not just a matter of practicality. It's also a measure of respect for people's time, for their input, for their sacrifice of time, for their willingness to disrupt their lives, to disrupt their regularly scheduled appointments and work schedules and so forth. It's a gesture. And more often than not, the amount is pretty paltry, but there could be some reassessment. And I think there should be a reassessment of the amount. And I vehemently push back against any concept that is promoted concerning this issue of coercion. My strongly held belief is that it's impossible to coerce anyone that you have adequately informed about any details concerning a study. I think it's a paternalistic attitude that presumes people cannot make their own minds up if given adequate information on which to go on. So I would say that, yes, increasing the amount of compensation across the board would be a shot in the arm. No question. No question at all. People need to feel valued and respected, and they want to know that the calculus that they're creating in their own minds makes sense for whatever you're asking them to do within the design of the protocol. There needs to be some reckoning in their own minds that it's worth it.
Yeah. Now they do travel reimbursements for cancer clinical trials. So usually these are late stage cancer patients who are really given a pretty grim prognosis. So it's either a clinical trial or they're being sent home to hospice. So it's coercion. It's not coercion at all. It's either end of life or one last Hail Mary, and it's a clinical trial.
Absolutely. But at the end of the day, it needs to be their own decision.
Absolutely.
As to, what value they place on their participation.
And the cost of a plane ticket is access. And
absolutely.
Everybody should have that opportunity.
Yes. I mean, we could talk completely on this issue.
Right, exactly.
I have some ideas around how to change the entire game with the compensation being increased and making participants feel like invested research partners.
So how do you build back that trust when you're talking about the history in Tuskegee, and how do you build back that trust to get Black and brown communities more engaged after the history of mistrust?
To me, it boils down to one thing: transparency.
Yeah.
It's all about feeling as if you're getting the full story, as if all the information about the study is being disclosed, that nothing's being withheld. Obviously, the message has to be crafted in such a way that people understand, it's called research for a reason. There are a lot of unknowns, but to the extent that something, that you are willing to disclose that, share it, put it into bite-sized pieces that people who don't have medical degrees can understand.
Dorcas, let me bring you back into the conversation, because I know you do a lot of bias training, and I want to find out what your role in that is, and why that is so important, and how maybe it lends itself to what we're talking about right now with the trust and the transparency, and how it opens doors.
Absolutely. And I think one of the things that I like to encourage teams who are working on this issue to think about is revisiting our assumptions about groups of people and individuals who are different from ourselves, who we don't spend a lot of time around, whose cultural approaches are quite foreign in terms of our own lived experience. And when we have the ability to actually observe and appreciate difference as we are trying to deliver services or to deliver a campaign message, for example, why vaccines would be important, it is very important to be able to understand what some of the biases are in how different communities think about things. I'll give a very quick example in terms of actionable things that can be done to regain trust. There is an example that I always find very poignant, and that is a public health clinic in a predominantly Hispanic community was doing some research on maternal child health. And they really wanted to be able to gather qualitative information along with the quantitative data to be able to craft interventions to best support these mother and children and their families. And because it was a primarily Hispanic population, one of the questions that were asked is, are you married? And this was overwhelming and offensive to some of the young women who participated in the program, because they were young Catholic women. And for them, being asked if they were married when they were showing up to a maternal child health clinic was the assumption that they were not in what they perceived as a traditional appropriate relationship to have children. And so the clinical staff immediately recognized that they were actually offending some of the participants. visitors to their public health clinic, and basically apologized immediately and explained, I am asking these questions, we are asking these questions so that we can design programs that best meet your needs. And if I offended you, and made an assumption about your marital status or your motherhood, it was not my intent. And that immediately changes the dynamic, because whatever immediate trust was broken, there's an opportunity to gain that closeness by being transparent about why certain things are being asked and why certain things are being done that may be perceived inappropriate by the group that you're actually trying to help.
Oh, that's so interesting. So how is the diversity and the bias training that you're doing changing, making a shift? Do you see a radical shift with the work that you're doing?
Well, I'm doing that kind of work in two different populations. So, for the public health and health services organizations, it very much is helping to dismantle some of the conditioned attitudes and beliefs about low-income families. That it's not about a lack of interest or desire to be healthy. It's not about disagreeing or not being adherent to the direction of what is being provided as an intervention. It is really about the practitioner at whatever level they are to really look at their own biases about what are they assuming about that household? What are they assuming about that family's lived experience that may be interfering with their ability to fulfill a diagnosis or a suggestion for a certain medical intervention? We really need to look at the patient journey and understand where we might infuse bias that we're not even aware of.
Very interesting. So, Elisa, how do we take a look at the patient journey and include the data that you're working on? How does that all come together? What are you doing with the data and the patient journey, and how I'm also curious, how has COVID shifted the work that you're doing?
I'm so glad you asked that, because as Alison was speaking, I wanted to say just, yes, by the way. So thank you for asking that. So, for example, one of our clients was specifically focused on creating access for blood banks to draw COVID-19 recovered patient plasma to serve as a therapeutic before, for example, that there was any vaccines available in the market or even any other agents but that. And what we found out is there was so much data available in the hospital systems, and yet there was no way to get to it. There was so much red tape. Yes, there is a reason it's there. We are protecting patients. But at the same time, the red tape actually prevented really patients getting help. So I think what we need to really talk about is the way to de-anonymize patient data, obviously. De-identify it, not fully anonymize it. Obviously, we cannot do it, but de-identify it, but yet allow it to be mineable so that you can get to the people who might be interested in helping. As part of that journey, I have found out about a patient who has traveled all the way from Dallas to Houston just so that she could donate plasma. And she was just out of the hospital a couple of days because she knew how important it was for her to be able to help. So, the patient journey can be really adapted to certain conditions and to certain needs that are out there. And I think we need to really get patients' input about how much they want their data to really be protected and how much they want to have a right to share it for the benefit of research.
Have you seen a shift just over the past year in this conversation?
I really have. And I think some of it we are seeing in the technology and the public sector, because we are seeing how the technology is adapting to meet the needs of the public sector and how the public sector is now listening to the needs of the patients and of the technology and providing it. To be honest, I don't think the advances in medicine really in COVID-19 research would have happened if we hadn't seen the shift. There has been really unprecedented ability to work together for researchers in different countries, for researchers in different institutions, and ability to really build trust. And I think technology has at least some, it has really provided some of the reference for that to happen.
Mm-hmm. And where do you think we're going? We've seen so much adaptation just in the past year. Where are we going with blockchain, with data, with I don't know if you want to, make a prediction on the trust piece. Maybe we don't want to go there, but or maybe you do. But can you project?
I'm actually thinking almost like a data marketplace, to be honest. A data marketplace where that pool of data is being transferred, and then very strict permissions given to every level of participant, so that you're able to draw from the data lake for research, potentially for making policy decisions, and yet a full ability for the patient to go back in and remove the data. I mean, I was just speaking to a doctor literally 10 minutes before our panel started, and he mentioned, for example, when you're coming into an urgent care clinic and you are giving them permission to look at your data, you're never ever actually taking it back unless you specifically know you should, and so that anyone working for that urgent care can access your personal data 10 years in the future. Why? Mm-hmm. You don't want to do that, especially when it comes to something really truly sensitive, for example, how potentially your sexual orientation, or your information when it comes to your STDs or what have you. There is no need to know this kind of information, and you have a right to know that you're able to plug that data in and then take it back, just so you're never in danger of having it mined without your consent.
Yeah. So Allison, let me turn to you. We were just talking about the shift over this past year and what we've seen, and also how COVID has kind of opened the door, maybe opened the wound too of what we've been seeing over history. A lot of people are just waking up to the disparities that have existed for many, many years. And they're like, oh, wow, this is here, but it's been there for a long, long time.
Absolutely.
We're waking up a little too late, but are we waking up? Do you think it's an awakening that will last? Do you think it's an awakening that is going to be that will make the change that we need to be made? What's your take?
That's the $60,000 question.
Yeah.
I firmly believe that we need to make haste while the getting's good, in terms of making sure that we don't recede back into the shadows again after the pandemic crescendos, and when we start returning back to some semblance of normalcy because we have access to vaccines and so forth. It is my intent. I don't know that I have a prediction per se about how everything is going to play out, but I have pledged to make sure that the patient voice and that of minorities and the whole diversity, equity, and inclusion piece becomes a standard, that it is that we're setting the bar so that the conversation is consistent, that we're not flash in the pan in terms of awareness across the board. I mean, we've been talking about this for decades. And, truth be known, the industry en masse has made overtures for the same amount of time about how important it is to create inroads for minority inclusion. It's just now that there seems to be some additional accountability piece attached to it that goes with the sense of urgency around the coronavirus.
Right. So it's time for action. And Yeah, high time for action. So and all of you,
time for action.
I'm sorry, say that again. I cut you off.
Way past time for action.
Yes, and that is why we're here. Because all of you guys are doing such, things that are leading toward action and changing people's perception. And so we don't want to just talk. We want to act. We want to inspire people to act, and change the way people, see themselves and the way they are doing things. So as we've talked about, this is a conference that is dedicated to going beyond just the conversation and providing actionable advice to the audience about how they can create, and we can all create a more inclusive world. So I want to invite you all to have a dialogue with each other around this idea of action and share your best insights and actionable advice. And Allison, you started, and I want to go back to you as well. But Dorcas, let's go to you and ask you about maybe some of your action items. What are you doing in your space? And what do you think, what's your advice for our viewers about what they can do to promote this conversation, maybe share with a friend? What can they post on social media? I mean, just, some things that maybe you share with your community.
Absolutely. My strong belief is that the perfect storm that we found ourselves in, with the combination of the public health crisis of the pandemic and the social justice crisis that came about as a result of the George Floyd incident, led us to a place in our society where if we are not in public health, in medicine, in any industry for that matter, actively looking at equity-seeking behaviors, policies, procedures, then we are missing the mark. Mm-hmm. And to Allison's point, it can no longer be an add-on, a nice to have. What I'm seeing is a shift in leaders and managers really looking at how do we turn the lens of diversity, equity, inclusion to actually be an integral part of all of our strategic planning, of what we look at from a budgetary perspective, of how we're identifying our metrics. It is integrated as opposed to ancillary. And if we continue that momentum and do not become complacent, I do believe that we will start to see some of those shifts in the systemic issues that have really caused equity to not exist. Mm-hmm, mm-hmm. So I really and sorry, just one more thought on that, and that is we can't confuse equity with equality.
Yeah.
Because, people and communities and populations are coming into the mix at different levels of need, expectation, and efficacy in terms of being able to self-actualize what they need to be healthy and to be well. So we need to look at what does it mean to be equitable? How do we give populations and individuals what they need so that they can reach a level of equality? And I think that's a mind shift that we have to really start to get comfortable with. There's a difference between equity and equality, and we need to look at equity as what is the driving force of how we make decisions.
Yeah, no, that's a great differentiation. I appreciate you bringing that up. Just even to simplify it even more, just for somebody who maybe come across this conversation, who perhaps isn't even in the healthcare space and is white and is, I go back to when George Floyd happened and the sign that said, white people do something, speak up, do something. What can a white person, who maybe works in the healthcare industry, what can they do? What can they say? What can they, in the medical community? What is an actionable, simple item that they can do?
They can ask where the brown and black people are. Mm-hmm. And whether they're in the room. Mm-hmm. First and foremost, mm-hmm. that we have a place at the table, mm-hmm. and that no decisions are being made in a vacuum without our input.
Yep. Make sure there's a diverse community always having a conversation.
Absolutely. And from the beginning, to mm-hmm. Dorcas's point, that it's not ancillary, that it's mm-hmm. integral, mm-hmm. and that we're part of the planning process. Mm-hmm. That studies are not designed without our input to begin with.
Yep. Dorcas, anything else?
I would like to add, you said, looking industry agnostic, how do we encourage people to ask the right questions? And I think are very difficult, sometimes painful, self-assessment of, again, what are the assumptions that I am making about people who are different from me?
Yes.
I need to check my bias. I need to check how I, through my own upbringing, my own community, how I've developed attitudes and beliefs that may be interfering with my ability to actually support and empower my customers, my patients, my stakeholders, asking those really important self-assessment questions so that we begin to do work differently, ask questions differently, come up with solutions that are actually applicable and not based on a particular lens that might be quite skewed and quite biased.
Well, Lisa, anything with in terms of data that companies can be thinking about, action items for insurance companies or even for consumers who are thinking about their data?
Well, first of all, I think we need to listen. And in the technology space specifically, there is this divide between technologists and then consumers. And by consumers, I'm not just meaning individual users, but actually companies, like insurance companies, like I mentioned. So I think there is a great need to have open dialogues like this between different groups of stakeholders who are able to ask each other questions and really actualize where they can come into a larger infrastructure. The world has gotten so complex and the problems, I would not say insurmountable, but so major that we really cannot make our decisions in a vacuum. And if, for example, a technologist comes in saying that they have a solution for everything from data to inclusion, they're lying. They can't. Just as potentially someone coming in as a politician and saying, well, if only that technology existed, everything would be solved. But no, the dialogue is needed most of all.
Allison, one last question for you, and that is, do you have any other actionable advice that you think that we can, any takeaways for our viewers?
Don't make assumptions. Don't assume that we won't participate. Don't do that. Be forthright, be open, be accessible. Don't create studies that have unreasonable inclusion-exclusion criteria that bar us from participating right at the gate because we have comorbid conditions that typically create obstacles. So let's ease the patient burden for studies, compensate better, and pay close attention to the invitation list that you're using for patient recruitment.
Such important advice. You all have been so insightful and really informative, and I really appreciate the conversation. This is an important conversation. We could go on forever, and I hope that we do continue it. Really do.
Thank you, Laura.
Thank you for your good work.
And thank you to the other panelists.
Likewise, it's great.
Thank you very much. Yeah, you have been watching the Health Equity, Why Diversity Matters in Public Health. It does matter so much, and we thank you for watching. Check out all the other topics that we are covering because we brought together voices from all genres, genders, and geographies. For more fascinating conversations like this one, you can visit nonobviousdiversity.com, and also our official summit hashtag is #nonobviousdiversity. Thank you for joining us today. I'm Laura Evans.